I started my residency training in general surgery, so that's what I was interested in med school. So I ended up going to one of the big district public hospitals in Tanzania. This is probably the thing that really got me into global health at the beginning, was this operation. So a man came in, he had had his prostate removed, and he had a really bad infection after, and so he had to go get a procedure to fix basically the infection. And for whatever reason, the surgeon decided that, or there was no anesthetist around, or the patient didn't have money to afford anesthetic, but so the patient was operated on wide awake for this open abdominal procedure. And it was just this horrible experience of him being awake and screaming and clenching his fists. And so I remember in the middle of the procedure, his face was uncovered and this mosquito just landed on his chest. And I was just sort of looking at it and thinking, oh my God, this is insane. I think what anybody would think, that it's just impossible. How could something like that happen to people? But what's, more shocking after doing all this training and going overseas so much is that it's actually much more common for stuff like that to happen than for the healthcare system that we have here in Canada, in the US and the Western world, basically, in high-income countries. It's actually, we're probably the exception and not the rule in the way our healthcare system works. Cherniak. I'm a family and emergency doctor. I'm working in the emergency department at 3 different hospitals in the GTA. I'm the executive director of Bridge to Health Medical and Dental. It's an NGO and we work over in rural Uganda. And then I'm teaching this advanced cardiac life support course at Sunnybrook. And then I'm working off and on in Baltimore. But outside of all of the work stuff, love to travel. Basically as much as possible. Find it somewhat difficult to sit still in one place for too long. I think as a kid I was sort of happy-go-lucky. I've got my 3 brothers. I'm the youngest of the 3. Jason is the oldest, Harry's the middle. Really randomly I wanted to be a chef when I was younger, actually. I think it's probably because the guys in my family were always the cooks. So we used to always have these things where we would basically make different meals, and used to always love just getting into the kitchen. And then in grade 10, a little bit personal, but my brother, Harry, actually was pretty sick, so he was in the hospital. And then I don't think it really clicked until maybe I was already in medical school, but that was kind of the click moment, I think, where all of a sudden, internally, just kind of shifted from being a chef to just wanting to pursue science and medicine. So the reason I pursued the Masters of Public Health at Hopkins is because I've been doing all of this work in global health, and so I sort of wanted to get a better understanding of the basics of the stuff I was actually doing. There's a lot of criticism, good criticism these days, around organizations that do short trips overseas, because there's a lot of potential to do harm to a local community. So if you show up for a couple of weeks and you diagnose somebody, but then you haven't thought about, well, what happens next after we go home? What we really try to do to be sustainable is we take a long time to really put all the pieces together. Who are our partners going to be on the ground? After we diagnose somebody with, a cancer that's spread through their body, how are they going to get the radiation treatment? How are they going to get the surgery? Who's going to pay for it? Where are they going to live? How are they going to get from their home, 150 kilometers in the mountains in a rural area with no roads? When we started the whole thing, we started Bridge to Health, I had basically no experience in public health or in the idea of how healthcare systems really worked. And as time went on, kind of really had this realization that you can't really make a sustainable or big level change without getting the Ministry of Health involved. Basically, you can't address healthcare without also addressing poverty and education. Anything Bridge to Health does is based on the needs of the local community. So when we first went to Uganda, we spoke with the local organization, KIFO, and their executive director, Dr. Ngio, and we asked, what do you guys think is the biggest issue facing the community? And at that time, the big thing that came up was that too many women were dying in childbirth and not enough moms were coming for screening while they were pregnant. And we were talking with the local doc, and so why don't we offer portable ultrasound as an incentive to come for screening? According to the local doc, getting a free ultrasound scan is like too good to be true in the rural communities. So we did a study, and through that study, we were actually able to purchase, through fundraising, 2 portable ultrasound machines and organize a whole mother health clinic, basically, on the side of our medical and dental outreach. So over 8 days, we were able to see over 150 pregnant women and test them for HIV, infectious diseases, give them ultrasounds, talk about family planning, give them basic vitamins and supplements. We left in 2014. The machines have been used once a month for screening up to 40 women for ultrasound scans. The goal is to get this paper published finally, hopefully, and or just sort of get the results out there so that basically we can try to encourage NGOs and ministries of health to buy machines for their programs. Because, it's something that's just standard of care in Canada or the US. You would never expect to go through your whole pregnancy without getting a single ultrasound scan. It's easy when you do a public health degree. The mantra at Hopkins is saving lives millions at a time. So you're trying to think about a population of people. But when you're actually a clinical care provider, sometimes it is that individual thing that really does make a difference. We had a 40-year-old lady with appendicitis who came in. Well, she came in with pain in her stomach for a couple of days. And she just hadn't had anything to eat or drink for 3 days. And her blood pressure was so low, it was 60 on 0, actually. We had to take it 5 different times to confirm that's what it actually was, because she was such a strong lady. She was actually sitting upright versus most people would be passed out unconscious. And so we were able to give her lots of fluids, and she got surgery and did fine afterwards. So for sure, she would have died within 10 to 12 hours, maybe less, had we not happened to be in that community that day. People would argue that that's not sustainable, but we know that we helped a few hundred people that we saw in clinic that day, and that person in particular who would have died otherwise. So you kind of have to make that decision of, well, what community are we going to go to and how many people can we see on this particular day, versus if we take an extra 2 hours to specifically train Ugandan healthcare workers. Because we might miss that person who's really ill, but then that Ugandan healthcare worker who gets better training might be able to help 10 of those people over the next 5 years while that person's working. Ultimately, the goal is that we don't need to be there anymore, that the healthcare system will be self-sufficient. We're not going to be able to do that by ourselves, but we want to work with everybody to try to help that process move forward. Healthcare really impacts all of us in the same way, no matter where you live around the world.